Welcome. Thank you so much for joining us. My name is Christina Lively. I'm the program manager for the Master of Medical Sciences in Global Health Delivery program. And our occasion for getting together today is to kick off the celebration for the 10th anniversary of the launch of the Master of Medical Sciences in Global Health Delivery. 10 years ago, we started our program with just 4 students. And I should say, years before that, people in our department, the Department of Global Health and Social Medicine at Harvard Medical School, started envisioning this program and envisioning other programs that we'll talk about today. I also want to mention that this year marks the 150th anniversary of the Department of Global Health and Social Medicine. So many of you may have joined us for events celebrating that milestone for the past academic year. And now we are kind of launching right into the Master of Medical Sciences in Global Health Delivery 10th anniversary celebration. I want to let people know that this is just the first of many events. We will have another event on June 29th with an alum, David Angelson, and also faculty member Ann Becker. So our series will feature faculty, as we are featuring today, and also alumni of our program. And so without further ado, I'm going to go ahead and turn it over to our program director, Joia Mukherjee.
Yeah. Good morning, everybody. It's great to see you. Sorry, I'm just trying to share my slides. Sorry, I know how to do this. I've been doing this for 2 years now. It's always confusing which one you're getting. Okay. All right, and then we'll go to slideshow. So I'm just delighted to be here celebrating these 10 years. It went very fast, as Joe was just saying. And I think what we've shown is that there is a discipline of global health delivery, and then there's also a discipline to teaching it. And I'm glad, so delighted that Howard and Marshall are here. I remember a dinner many years ago with Marshall before we started the master's program. And we were talking about ways to credential people and how hard it was to get people the adequate credentials to do the work that they were doing. And Marshall just said, just create a master's program. And when I told that to Paul said, well, I've been saying that for 20 years. So, you know, I think, and Howard, of course, is the father of all of our training programs, the Division of Global Health Equity, as well as the residency in Global Health Equity. So it's just an honor to have you both here. And I know, you know, Paul loved teaching. He always said, first patients, second students. And so I just wanted to give a very short overview. I have a bazillion slides. I'm not going to use all bazillion, but I want to give a brief overview of why teaching global health is so important and why now. Why are we where we are? And so I'll say that, you know, everybody who learns public health knows about the Broad Street pump. The Broad Street pump, which didn't look like this back in John Snow's time, was, you know, the source. John Snow mapped the Broad Street pump as the source of a cholera epidemic and took the handle off the pump. And in a lot of ways, John Snow is considered certainly the father of public health. And also that idea of prevention, taking the handle off the pump, it really went on for many, many years as the right thing to do. And I think what we're so proud of in global health delivery is the analysis that we have is far deeper. And it's deeper because of the lived experience and the practice of people in the Brigham and in the division, the care for patients, but it's also deeper because we're seated in the Department of Global Health and Social Medicine. So what we started thinking about many, many years ago, what Paul started thinking about is, so what happens when you take that handle off the pump? You know, where do people get water? And, you know, are they going to be happy about that? That's not really So it's not addressing the root causes, which in the case of this cholera epidemic was really that people were dumping sewage into the river above the pump. And of course, those people were wealthier people. So they say that something flows downhill or downriver. And I think a lot of our social medicine work is in that. So when many of us started, there was very little care in public health. And the delivery of care was considered too hard. And yet here we are, this is in Haiti when the cholera outbreak first came to our small, or not so small, hospital in St. Mark, where we had spent decades training doctors and nurses, community health workers, refurbishing infrastructure. And we were within about 3 days able to make it into a proper cholera treatment unit. Why? Because our staff recognized that something unusual was happening immediately, because the community health workers could go and alert people. And because we already had on hand IV fluids, doxycycline, zinc, all of the things that one would need to treat cholera. So for us, global health delivery is moving toward the entire burden of disease and treating whatever people have. It's really analyzing and addressing inequalities. And then to do that, you need to teach and train people to do the work that they would love to do if they had the right treatment. So for example, in Haiti, our doctors, the doctor who ran this hospital for many years, Dr. Charles Patrick Almazor, has an MPH. He was a Fulbright scholar. He's a Haitian trained physician, worked in both Haiti and Rwanda. And he had had many years of ad hoc training to do this work. But what we realized is we wanted to formalize the training of how people analyzed a problem, how they really studied it in a social medicine way, with proximity to patients, with analyzing the social determinants of health, and also then working to remediate the barriers so that equity, which is that the poorest get the same care as the wealthy and have the same outcomes and the same access, that equity is only possible through that social medicine approach, proximity, analysis of the social determinants, and work to remediate them as we're delivering healthcare. So I think that the masters grew out of those two needs: one, to deliver care, which was novel and still is in many places, and two, to analyze the social roots and build systems that will be equitable and study of how to do that. So, sorry, I don't know if you get to see that. So, a lot of our work, this is a research program that we designed. It's a 2-year program, and all of our students, the lion's share of our students, have been from the Global South, and are frontline providers or activists or people that are really working at the interface of delivery. And, we are very used to, in academic medicine, translational research of bench to bedside. That's the T1 block, according to the IOM. We're used to the bedside to clinical practice. That's the T2 block. But what we haven't done adequately is translation of these best practices into an equity strategy. And that's what the program is all about. We know how to treat HIV, but do we know how to treat HIV in people that are migrants? We know how to prevent COVID, but do we know how to prevent COVID when people cannot isolate or quarantine? So that is the work that our students have now been doing for 10 years, and they're doing it brilliantly because they themselves are very proximate to the problems. So I'm not going to go over the horrors of prevention only, but I'll just say that a lot of our work at Partners in Health, where I am the chief medical officer, has led to this work because we said to do all this, you need to actually change policy. And so some of our graduates really, they use their research to actually change policy. they're in ministries of health, they're in large NGOs, and so they can say, okay, based on this evidence, this is how you deliver care. And that is the kind of work that needs to be done to really expand what's possible. Scholarship in global health delivery can be everything from reporting about drug prices to funds resources. It can be reporting about how community health workers integrate with district hospitals and health centers. And so that is the kind of work we did. And so let me, say that around the world, there is an effort. And largely, by this group, whether it's University of Global Health Equity, the University Hospital in Mirebalais, to say, what do we need to formally train people to deliver the care, to study the care, and improve the care? And so I've been just really fortunate to work with the 3 people on this panel to help our students go through this. And I'm just going to highlight a couple of our students. This is us teaching global health and social medicine, which is really about the social roots. Here are a few of our students. There's Mary Kay teaching. You see, we're all animated because we love this work and we're passionate about it. And here's Hannah Gilbert. Our students are, they come with the idea that there are very technical things, and often it's a lift for them to really take in the social determinants, the historical forces, the political forces. But once they get it, they of course know it because they've lived it. The mentored research for us is so important because it's a way that also we combat brain drain. We say your work, the interesting work is in the field. That doesn't mean you might not choose to immigrate or go on for further degrees, but I think people realize the richness of the work they're doing and the enormous capacity to improve it. So these are our students, 113 students from 37 countries around the world. As you see, we have a lot from Haiti, but we're not apologizing for that. That's Paul's imprimatur on the program, but from all over. And I think, to a person, they have loved learning this deeper social medicine approach and delivery of care, focusing on delivery of care. Our students have authored 147 publications. And again, these are frontline providers, nurses, midwives, laboratory technicians who now are Harvard graduates and have become scholars. Many of them first author papers, senior author, and we've had a lot of our students be involved in COVID delivery and the analysis of the COVID-19 programs in their own countries. And a couple of our students have won the very prestigious HMS Richardson Fellowship for their projects. So they are top flight students. They come in, most of them are mid-career professionals. The level of education they had is variable. So, absolute kudos to our faculty to meet people where they are and really have the growth mindset in education. Clinical, academic, nonprofit. Here's Yasa Lavala, who is a Mandela Fellow before she came to us at the MMSc program. She's a midwife. She's now doing a PhD. And just some of the positions, we've had a lot of people go to the NGO world. A lot of people become teachers as well. And all of them, I think, consider themselves scholars at this point. A couple more, Danta, BNMA, and I'm going to just stop there and turn it over to my colleague and friend Joe Rhatigan to talk more about how we started the teaching of global health delivery and how it's expanded over the years. Joe.
Thanks, Joia. I'm going to share my screen. I hope. Great. Thanks. And thanks, Joia. And thanks for your leadership, Joia, in this program. I mean, you've been the heart and soul of the master's program, as every graduate will attest to. And it's just been amazing to be part of it. And also thanks to Rebecca and Mary Kay, who've been my colleagues in GHDI for over a decade now. I think we're on 14 years, is it? Maybe our 14th year this year, I think, right? And it's just been an amazing set of an amazing team to work with. It's really been my privilege. I'm going to talk a little bit about what our particular approach to teaching global health delivery and global health equity. We think we have a method that works quite well that we just want to share with you all, because sometimes you'll hear about, case teaching and stuff, and it can be a little mystifying at times. It's actually quite simple. And I just wanted to go through that with you a little bit and talk to you about how we've used that approach in a number of different settings, and why we think it's so effective. So as you can imagine, as Joia was describing, when you're looking at delivery, healthcare delivery, it's a complicated problem. It's a complicated issue. It involves many non-health disciplines. It involves problems outside of the small area that you're able to control. So if you're trying to, as Joia was saying, deliver an HIV treatment program in a rural part of, let's say, Rwanda, you're not only worried about all the health-related concerns, but you're also worried about things like the roads, the political environment, the cultural and sociological environment, demographics, things that as physicians and clinicians, we're often not taught, and yet are incredibly important, especially when you're working in resource-limited settings. In the States, we can take a lot of this stuff for granted. We can take for granted that we can hire folks that are going to be well-educated and well-trained. We can take for granted that they'll be running water and electricity. We can take for granted that people will be able to find their way to our clinics somehow on public transportation or other ways. All of those we can't assume are going to be present in a lot of the places where we most need to work for that equity agenda. And so we've come up with a method through case studies that help learners appreciate the complexity of these environments and hopefully able to abstract generalized lessons that they can apply to their own particular problems that they might be dealing with. So just like I was saying, some of the challenges we see is that many of these environments are quite unique. Like if you go to Weintraub, it's much different than if you went to someplace in Eastern Europe, let's say, that might be looking at very similar types of problems. But the environments are much different. The cultural environments are different. The demographics are different. The weather's different. The climate's different. And so just being able to generalize something that's able to work in one environment might not completely be easily adaptable to another. And trying to understand these influences of local context and resources on the program itself. Understanding how to deal with a lack of healthcare infrastructure, which can often be, a problem, especially in the work that Partners in Health does, the first problem one needs to tackle. And Paul, of course, was such a large proponent of this, of trying to rehabilitate the physical infrastructure so that then the program can thrive. There's often lack of good data. At the business school, they're constantly talking about, grabbing more and more data about outcomes, about inputs, so that they can better manage their enterprises. At the level that many of these health projects take place in, again, because of the equity agenda, there's not good data. And so folks need to manage with very little data often until those systems can be built up. And then the constant trade-off that we're constantly looking at of solutions that might work locally, but are unclear whether they can be scaled. And whether scaling is actually something that we need to do, or should we just be building more local solutions? This is a big debate in global health. On the Partners in Health side, right, we tend to try to fix things at the local level and then generalize those lessons and try to spread that way. In Rwanda, Haiti are great examples of this, right? Innovating in one district, trying to solve the problems in that particular district, and then trying to replicate those in other districts, as opposed to other solutions and other groups in global health that try to design a national level or a regional level solution and then implement that across a lot of programs. We could talk for hours about the benefits and trade-offs in those two decisions. So some key aspects of healthcare delivery that, you know, are obvious once one thinks about, but I just want to call out really quickly to just show you how broad the discussion often in classes. So, you know, at the very basic level, there's the whole bit of data and science around needs assessment, surveillance, and epidemiological data. And in COVID, again, we saw, right, this was often a very contested area about what the true burden of disease is, as Joia likes to say. And what really is, you know, we know what sometimes the politically important diseases are. We know which ones are often hidden, but how do we actually see the truth behind some of the data that were presented by governments or other entities? Understanding how to relate to the community, which is critical, right? This is not, we're dealing with people here. This is not, you know, we'll often talk in numbers and we'll talk in, you know, generalities, but at the end of the day, our programs touch people, individual people's lives and individual communities. And how do we engage in those communities and those people to make this the most equitable and valuable experience for them? Strategy and program design. Again, we can talk about this for hours, but what are we going to do and why are we going to do it and why do we think that's going to make a difference? And then how do we design a program to be able to do that? Financing, again, you know, something that you can get a degree in at the business school, but that's critical for many of these projects, right? Having not only obtaining resources, but managing those resources and being good stewards of those resources. Management and operations at the very, you know, basic level. We're running programs that have humans in them that must deliver services that we need to manage and train and cultivate. There's information that's being generated that we need to process and analyze and feed back. There's the whole supply chain, and in things like MDR-TB and HIV, where we need uninterrupted supply of medications. There's forecasting, there's ordering, there's procurement, there's distribution. All of these things need to happen seamlessly and in the right order and with the most cost-effective ways of doing it. And then all the other processes that we need to deal with. How do we get a patient into the clinic? Once a patient's in the clinic, how often do they come to follow up? How do we ensure that they come for follow-up? When tests are ordered, how do we make sure that that information is conveyed to the people who need to act upon it? There's the level of government and health system interactions as well, which, again, you know, you can get a degree in political economy and political analysis to look at, but in the real world are often, what are our relationships with our counterparts in the government and the Ministry of Health? How do we relate to them? How do we show them that we're good partners? And how do we become good partners? How do we listen to what their needs are and then reflect that in our priorities? And how do we interact with the overall health system? Something I'll talk about in a minute. And then there's just the level of evaluation, quality improvement. How do we know what we're doing is meeting our goals and the goals of the communities we're serving? And how do we make that better? So these tend to be all the things that come out in our classes as we're talking about the cases. So what is a case? I've been talking about a case now for 5 minutes. What is that? It's basically a real life situation. It's not, we don't aspire to be historians or journalists. We might not include everything in a case that happens, but everything that we include will really have happened.
Much to Paul's chagrin.
Right, exactly. Paul used to say that, you know, our cases are often, you know, 12 to 20 pages. He'd be like, they should be 100 to 200. So they're not this thick, they're not this thick anthropology that Paul loved, but they're, we think they're a reasonable description of what happens through the eyes of the people involved in a proactive way that allows you to live in their shoes and try to make decisions, kind of make the same decisions that people had to make with the information that they had at the time. And why do we do this? Well, one is just acquiring knowledge, right? There's things that come up in class, and this is stuff that all of us have encountered in our teaching that students just don't know. It might be, we have a wide range of students in our classes. Some are medical doctors and clinicians. Others are social workers or even pharmacists, and some are more on the kind of public health realm without a lot of clinical experience. So sometimes that knowledge can be how do you treat MDR-TB? What does malaria prevention look like? But a lot of that knowledge, we know, right? Adult learners are very good at acquiring knowledge themselves. They don't need us to help them look something up on the internet or read about it. So even though that's something that happens, really we're focused on the next three domains. One is developing skills. And the difference between this, right, is just the simple, analogy of learning how to play tennis. I could pretty much explain to you how to swing a tennis racket in 5 or 10 minutes. And you will know that, you will have that knowledge. You can acquire that knowledge of knowing how to swing a tennis racket. But actually being able to swing that tennis racket well and hit the ball effectively will require, hours and hours of practice. And that is how we develop skills. We develop skills by applying our knowledge with a coach or with someone to help us gauge our performance. And that's what we try to do in class. We'll often present 10 or 15 cases over 3 to 4 weeks so that students constantly are looking at new problems, new situations, and then trying to get better at analyzing it. Forming attitudes and values, which we are very clear about. This is not a value neutral space. We respect other people's values around, the cost effectiveness or the trade-offs in scaling, but we need to put those on the table and we need to discuss them and we need to examine them. Because again, this is the real world. This is the purpose of education, is to understand and interrogate our own attitudes and values, hear others, and then come up with ones that we feel that we can live with. And I think this is one of the reasons that many of our students find our classes very refreshing because we put it right out there. This notion of virtual experiential learning. This is back before virtual was we used this term back before virtual was applied to everything we do post-COVID. But this notion that we can't take our students, we can't take a classroom of students to 10 different countries in 3 different weeks and learn all about these programs. We can translate that into case studies and allow them to try to understand the context. We can never really duplicate it, but it gives folks a chance to walk in the shoes of the people who actually make these decisions. I'm just going to talk about this really quickly, but we essentially have all come up with a framework that we use in teaching these cases. So, we don't just throw our students into the cases blindly. We give them basically a 4-part framework that we ask them to think about and analyze the cases through. We're going to talk about this just very quickly, and we've written stuff about this that you can read. But the first level we often interrogate is the local context, getting students to understand not only the very local questions, but questions at the national level. What's the GDP? How many resources are available in the public sector? What's the workforce distribution like? What's the history of the country? Why do we have the problems that we do? What is the historical context here? What's the social and cultural context that we're working in? And this is a domain that, again, students often find very refreshing because they're often not talked about in many of their other classes in global health. And then understanding the value chain. Basically, this is just a very simple notion of when you're doing a health program, you're going to do different things at different times, and how do you link those things together? Joy and I wrote a paper about the value chain in HIV care. And again, very simple notion of if you're going to set up an HIV program, you're going to be doing some prevention work, you're going to be doing screening work, you're going to be doing work where you're engaging people in care and starting therapy. You're going to have a whole part of your program that's going to manage people once they're on ARTs. When people become pregnant, you're going to manage those, that event and help women have a safe pregnancy and have babies not be born without HIV. And how do you link those things together? Where do they happen? What kind of information flows across those activities? Who does what and when? That's all part of understanding the value chain. And again, this is something we'll often ask students to construct with us in class from their reading of the case. And then the third level is basically just the management level. How well do they manage their operations? Like, is this an organization that is, well run, good leadership, that has, have worked on creating good supply chains, both of goods and people, that have good strategies of getting people in the door and engaging the population and then keeping them engaged in therapy or treatment. And then the fourth level is, how does this program work with the overall health system? Is it a program that stands alone and has its own mission, regardless of what the Ministry of Health thinks? Or is it a program that is trying to talk to the ministry to understand the larger context in the country and that's trying to fit into an overall national strategic plan? Is it a program that's trying to build local capacity, or is it a program that's just trying to grab as much resources from other sectors of the economy that they can to improve their performance? So again, we have long discussions in class about any number of these levels of analysis. And why do we do this? Why do we have students read stuff and then talk about it in class? It's a chance for them to analyze and synthesize complex information, as I've just described. Also, we find that in class, it's really helpful for students to talk this stuff out. It forces people to understand conflicting viewpoints, because people will come at this from very different perspectives. And part of our job as case moderators, and all of us can speak to this, is trying to get people to understand each other's point of view. Not necessarily to say that one's better than the other, but to understand what's behind that point of view. Why do you think the way you do? And because we're all looking at the same information. The notion of needing to make decisions with imperfect information is something we all need to do. And the more we get a chance to practice that, the better. And then trying to persuade and inspire people who think differently. We are very clear with our students that, they need to practice being able to get up in front of their peers and explain their point of views and listen to people who disagree with them. And we really try to prod people, especially some of the more quiet students, to do that. It's a safe environment. They're going to need to do this in their professional lives, and this is a good place to learn that. And then why is this good for teaching global health? The business school likes to, say that they kind of invented this. Personally, I think we've been doing this in medicine for, millennia, where we talk about a patient's problems and then try to understand the roots of them and then come up with a way to solve them. But it also forces us in global health. We often sit within our discipline in global health, whether we're epidemiologists or clinicians or public health experts. This forces us to bring in other modes of inquiry and integrate them in our analysis. And we hope that these are rich descriptions of the complexity that we see in the real world, instead of a reductionist kind of model that just tries to wean things down to their most essential, what the writer or the investigator thinks are the most essential components. ours is an attempt to kind of bring in all that sticky, kind of complicated real world information. Where have we used these cases? Rebecca's going to talk about hopefully the development of the cases a little bit, and the case library, which is now quite large. But we all started teaching together in GHP 532 back in January of 2008, which seems like a lifetime ago. We've all been teaching that course every one to two times a year. It's often taught in the spring semester at HSPH as well as in GHDI during the summer semester. So we've had over 20 iterations of this course now, with a large number of both MPH students, GHDI, master's students, MD, MPH students from HMS. GHDI, which we've been talking about, and Rebecca's going to talk more about. We started using these cases at the invitation of Dr. Agnes Binagwahu in Rwanda, and we've given trainings for the Rwandan Ministry of Health every year from 2012 to 2016. And then in 2016, when the master's launched, which was based on the Harvard Master's Program at UGHE, we started using cases there. They're used around Harvard, at the business school, and at the Kennedy School. Many other universities have used them. As Rebecca described, they're freely available on a website for download, as well as for the teaching materials. Many PIH sites have taken this up and put on their own trainings using the cases, or have invited some of us to do that. And then other NGOs, Equal Health, Michelle Morse got a grant from the Radcliffe to put on a case writing seminar. She invited a number of folks from allied NGOs to come and created a small case library of teaching cases looking at barriers to healthcare. So, hopefully this has been a useful method that other people have been able to take up and adapt to their own uses. Just to leave you with a little photo, this is from 2012 when Dr. Binagwahu, who's sitting there next to the handsome guy in the blue shirt, first invited us to do this at the national level for many of her program directors. We had done smaller versions of this for her inner circle, but this is the first time we did this kind of for people across the Ministry of Health. So thank you very much. And I'm not sure who's next.
Should we have Mary Kay Smith Fawzi continue talking more about teaching, and then we'll have Rebecca Weintraub speak? Is that okay?
Okay. Thanks, Christina. Thanks, Joe. So I'll also share my screen. Let's see. I just wanted to make sure the lighting here is better. Okay, can people see my slides? Okay, sorry about that. So in thinking and following up with what Joia and what Joe were talking about, I was thinking a lot about the past maybe 10, now almost 15 years with GHDI, and just reflecting back on what we've done, how we've engaged students, what students have brought to the program, like what Joe was saying, their broad range of experiences. I feel like over the years, the students have taught us a lot. What we often do in the courses that, the methods courses that we teach, meaning Hannah Gilbert, Nadim Kasmani, Marcello Pagano. We teach the methods courses for the global health delivery, as well as the GHDI programs. And what we find is we try to think about what are we trying to teach, and we try to teach research methods. And this is something that Hannah and Nadim and I share in our mixed methods class. And it actually was introduced originally in the very first year we taught mixed methods. I can't take credit for this. Cesar Abadia, he's an anthropologist who now teaches at the University of Connecticut. He brought this into the course, and we retained this because it's one of the easiest ways, I think, of teaching social constructionism. So basically, we asked students to look at this image or this painting. A few students know art history and know what this was. Before Cesar introduced this, I had never known what this was. So we asked students in 30 seconds, what is the first thing that you see about this? And it's really fascinating because we asked them to just think in a split second, and everybody has a totally different interpretation, and they highlight different things, and we find different things. And many students obviously see, class differences and so on, and inequity, and that's core. This is obviously the royal family, etc. Actually, in Spain, this is like historical, back to the 1600s, but basically what's fascinating about this is that each student sees this in a different way. And what we try to share at that point is that there are so many ways of seeing the world, but what we see, it may not be actually what is there, right? So for example, you can look at this and you can say, well, these are three sisters, right? But they're in fact not sisters. Two of them are like, basically the Las Meninas, which are like these like ladies in waiting, so to speak, for this young girl. So we try to use different methods to teach things like social constructionism. And then we would then contrast that with Picasso's version of the same painting. So when we are looking at research methods, and that's essentially what we're teaching in the epidemiologic and biostatistical methods in global health, which is what we teach in the July class through GHDI with Rebecca and with Joe. Nadim Kasmani and I teach the quantitative methods for global health delivery and the mixed methods for global health delivery. Hannah Gilbert, Nadim and I teach in the spring. And essentially, what we try to do is use a collaborative approach. So it's not like we just have this didactic approach that we just kind of share slides and then give a lecture, so to speak, but really is a dynamic interchange between students and the faculty. And what we've done over the years is we've essentially organized students into pods. And what this means is that, yes, they're groups. And so we talk about this and we use the term pods because orca whales, as you can see this image, organize themselves into pods. And that is one, they're sort of like the apex, animal in the ocean. But essentially, the reason they are is that they're collaborative. That is really their key to success. So the idea here is that it's a joint learning experience. The experience is that you help each other learn, which they naturally do, but by making it explicit, the students, you can see the students helping and fostering one another. So we really try to foster that. And it helps to develop a sense of camaraderie, and also and we try to organize the pods so that they're, fairly diverse, and try to think about students from different backgrounds within the same pod, so to speak. So what we found over the years too is that relationships are key. So especially what we found with the GHDI program, even in those 3.5 weeks, the students rapidly develop basically very close connection. And essentially through that, and especially with the master's program and working with students over time, we really try to foster a sense of trust. We really want to learn more about them, not only about the researcher, but who they are. Do they have families? what's going on for them. If there are challenges, we are, all of the faculty are open to hearing what those challenges are and working with students as they go through those. And to also create a safe environment where students can feel like they can take risks. Hannah and Nadeem and I always like, look, this is a growth mindset in the learning process. It's not like you're going to get everything right. We often say to students, look, if you knew all of this already, then you wouldn't have to be here. So they feel comfortable to ask questions and to engage. And we also try to create fun activities, like we'll have a Jeopardy game. Epidemiology, quite honestly, can be very dry content. So we try to make it engaging and fun. And also that would also help to foster the group cohesion. We also do use some of our own research in the teaching of research methods. And what's interesting here is that what we try to do is focus on what are some of our successes in some of our sort of operational or global health delivery research, but what have been some of our failures? What has not worked and why was it? And where did we go wrong? And so this way they can see, first of all, that nobody's perfect, right? That the real teachers are not the faculty, but the patients that you're working with or the communities you're working with, that essentially when you go back to the field and do your thesis research, they are the people in the field are your teachers, and that we kind of quote unquote the faculty are the facilitators of that learning process. And by showing what our failures are, that also kind of shows, okay, where do we go wrong? Why did that happen? An example was I was involved with a randomized controlled trial for HIV prevention, and we found it actually didn't reduce some key risk behaviors, right? So what does that really mean? Why did we end up seeing that? And so we share that with students and we discuss it and we debate it. But we also encourage students, obviously, throughout the course to share their own experiences. It's a really rich learning environment. The students come with, such depth of experience that we try to promote this as much as possible. And also thinking about uncertainty. So with global health delivery, there is a lot of unknown. And there's a huge amount of complexity. So that's where, specifically the mixed methods class, we say often you'll see at the end of the day, many students or most students will use mixed methods. And the reason I think is that a lot of what we're dealing with is extremely complex. If we could really solve the equity problem, we would have solved it by now. And so in order to really understand what's going on, using a mix of qualitative and quantitative methods in an informed way can really help to foster understanding. But it's not only about the methods. In the master's program, the whole idea is not to replicate an MPH. MPH already exists, right? So what we integrate through our research methods classes really is a discussion of values. We don't just say, okay, this is a case control study, this is a cohort study, this is a mixed methods convergence study. We do teach these things, but it's all within the context of values. And an example would be, we talk about a randomized control trial by Lallemant and colleagues that, it was published back in 2000, but the key element of that was they used AZT at varying dosages to prevent mother-to-child transmission of HIV, but the dosages were lower than what we had already known from an earlier study in, I think, 1994 in the United States that demonstrated that we could, in fact, prevent mother-to-child transmission using AZT at a higher dose. And so the question then is, what does this mean ethically when you're actually conducting a randomized controlled trial, when you know AZT can actually reduce transmission? And with this landmark study, the interesting thing with this landmark study was that at the end of the day, because of this publication, the cost of prevention of PMTCT went from like thousands of dollars to 500 per person. And so although you can say, well, they actually did a randomized controlled trial that was substandard from US standpoint, which I actually would have never performed this trial. But looking retrospectively, hundreds of thousands of women had access to PMTCT treatment because of the study. So it gets into this really complex, students really engage with this, and it's just an example of how complex global health delivery is. And we also really, in thinking of values, we try to integrate, essentially different values and thinking about, we talk about, this is like one slide we have actually every year include this in our first class of GHDI and also in our quantitative methods class. And it's just a reminder for students, what brings everybody together. This is just a quote from Paul we used in the fall, statistics no longer frighten us, but pictures of the starving children of Biafra, of Haiti, or of India with thousands sleeping in the streets ought to, which is a quote from Pathologies of Power. And these are images from Haiti. And we talk about the fact that we live in a world where, this young girl, this is in central Haiti, this young girl who was, really in severe malnutrition, which is really unconscionable in the 21st century, but yet Partners in Health, developed a program to treat this level of malnutrition. So yes, this is a situation of grave human rights violation, but to note that, but then also that there's hope that those situations can change. And we often use, inspirational quotes and just as a way of really, really retaining that inspiration, because research methods is very hard. It takes a lot of effort to really learn, to understand the material, and we want to really try to keep spirits up. And we also include, like, this is one, we invited, especially during COVID and everybody was online, we invited students to send pictures. This was a picture that one of the students, Ifra, had shared from Somaliland. So every student shared their images. This was a quote she shared with us: a little progress each day adds up to big results. I have to ask Ifra, who said that quote, but we would have students send inspirational quotes and images. This is, again, we also shared student artwork. This was Ginger Ramirez, who's just graduating this year, and she shared this artwork with us. And this was her image of COVID, and we talked about COVID. We used time, to actually touch upon that and the impact and the implications. And then what we found is that really what it boils down to is that whether it's the GHDI program for the summer or the master's program, each student comes with a dream. I think that's what I found to be most powerful over the last number of years, is that each student has a dream. They have a vision, and they all, like every single one of them, hands down, they all come. They want to make the world a better place. They see what Paul has done. They see, the vision that Partners in Health has had, and they want to continue that. Some of them have been actively involved with Partners in Health for many years, even before coming. Some of them worked with different NGOs. Some of them have worked for the government. Some of them even worked in research capacity, but they all come with a dream. And I feel like our goal as, faculty is really just to facilitate students attaining their dreams. And it could be that the challenge is that they often come with this gigantic project, and you're like, well, I think you might need to narrow it down a little, and that can be often very discouraging to students. They're like, really, do I have to narrow it down? I would really love to do all of this. And it's like, well, you only have a certain amount of time and so on. So the important thing is to try to help them to narrow down the project, but not to extinguish their dream. So to think, okay, this may be the first part of, a longer term project that you continue after you graduate, but that to really facilitate and foster those dreams. And really that's what, as faculty, really it's a collaborative process. We're constantly learning from students. We actually come and ask students to present, former students to present. We use former students' work to show what can be done and to really inspire current students. So I'll just stop there, and I'll just stop sharing my screen.
Great. Thanks so much, Mary Kay. So next we'll have Rebecca Weintraub speak.
So many thanks. And what an inspiring hour to start our Friday. I'm just first so honored to be a part of this incredible cohort. So Christina and Joia and Merlin, thank you for pulling us together to mark this moment. It really just feels like a bolus of energy, and there's so much expertise on the line. I want to be deep in the chat with you all. I cannot keep up, but I want to hear an update from everyone who's here. And I also just thank you, Howard and Marshall, for being here, because I think about the phenotype of leadership, to think about how do we build new sources of power, of influence, of using old institutions to do new and different things. There's so much you've seeded that it's enabling all of us to be here together. A few years ago, Dan Heath came and he visited Harvard, and he said, I have nothing to teach you all, but I want to learn from healthcare and public health. But I keep coming back to this quote, which I think is one of the core functions that we've done within the master's program in global health delivery, in the global health delivery intensive, and our collective work within the department. To succeed upstream, leaders must detect problems early, target leverage points in complex systems, find reliable ways to measure success, and pioneer new ways of working together, and embed their successes into systems to give them permanence. And I think of so much of the infrastructure that Joia and Mary Kay and Joe just spoke about, the pedagogical infrastructure, the frameworks, the tools, the expertise, your collective wisdom. I think this is actually how we start beginning to think upstream and leverage the expertise and wisdom as part of our collective. See if I can move along. I might have. 1 second, it's not letting me. Try that again. So I'm gonna do 5 slides. I just want to give you this is the slide that we keep putting up in GHP 555, because we think our frameworks, our tools, the cases, the collective wisdom need to do 2 things. Our leaders and managers in global health delivery need to improve the performance of the organization. Obviously, the lives saved, the medicines procured, the policies changed. And Mary Kay, you were talking about so much of the interaction between the students also simulate, in a sense, how we work with each other, the speed of decision-making, the commitment of stakeholders, the passion, the intention of the practice, and how we do that and scenario that within the classroom setting. Just want to give you a sense, Joe mentioned the cases in global health delivery, and also there's many folks on the line who have been a part of what cases should we write next. They've been interviewed for the case collection, they've become case researchers with us, they've introduced us. We've now interviewed probably 5,000 to 6,000 people for the case collection. And just to start us off in the beginning, on the lower bottom corner, you all may remember Indus Hospital in Pakistan. We have a longitudinal relationship in the Department of Global Health and Social Medicine with our colleagues. Several of the surgeons came to our first global health delivery intensive course, which established a longstanding relationship because Salman Khashoggi had known the team there. And it's just been an incredibly fruitful 14 years of collegial relationship, not only the case and GHDI, but research activities with our colleagues in Pakistan. Also, you can see the Kajabe Hospital here, where Robert Urviello had a wonderful team of surgical residents help write that case. And there's really interconnectivity here between so many of us on the call and the case collection, which I view as our collective effort. Right now, here are kind of 3 new cases that we've been able to put out in the midst of the last 12 months, 2 of which were written with one of our students who was part of the Global Health Delivery Intensive that first series of courses that we just mentioned. We then went to Senegal to research these cases. We met with colleagues of master's students, colleagues who had made introductions to us. We found a translator via a master's student who did an introduction. I mean, it's so incredibly interconnected that we view the case library, the teaching notes, the data that we've created from it, the exhibits as our collective work. We've also, as you all know, this has been an effort that we've made sure there are no barriers to access. So the cases, it's the only case library actually with Harvard Business Publishing that's at no cost to our students and faculty. So we have 500 active universities who are actively downloading the teaching notes every year. We've had 60,000 downloads of active users. And it's just been really a collective effort. And this is once again, Joe can remember the conversation that we had with Paul about how we name the cases, how we ensure the cases are free and accessible. This is truly kind of, you know, Paul's words are on every one of these pages, as so many folks around the world are utilizing them. And I just want to also note, we've had a wonderful collaboration with our colleagues at USAID, the World Health Organization, Tech Change. Also another global health delivery intensive alumni helped us establish this connection where we've created this board game and different versions of this board game that we play every year. So we've got 7 different versions of it now. This is one example, Architects of Digital Health. We played this with ministers of health, for example, have sat down at the board game. They've done quite well to think about health system failure. It's based off the game Pandemic, prior to the pandemic. So some of you who played that game before will recognize some of this. And we have many versions coming out if folks are interested. And many folks I know on the line have played this with us. So thank you for the early prototyping in class. And I also just wanted to share, there's just been, you know, several of our case research and discussions in class, especially over the last several years, had been about vaccine delivery, polio, measles. We're now working on smallpox. We had obviously so many important questions coming from our students about COVID-19 vaccines in March of 2020. And my inbox was filled with our alumni asking us these questions. We got Seth Berkley on the line, Prashant Yadav, who is one of our faculty members from the course. We began writing and thinking about how could we help our decision makers, including our alumni, prepare for this moment of uncertainty. And I do think it's this combination skill set that folks have received from this program, from the master's program, that helped translate some of the evidence base and the wisdom and expertise to help folks prepare. And pleased to dive into that if folks are interested. I'll just kind of land here. These are some of my takeaways from 10 years of the master's program and the quality of the students that I've been able to teach and learn from. One is the eagerness to have an R&D function within their delivery systems. People need resources, they need staffing to help design and test new pathways. Second, that there's so much expertise within the cohort of the master's students and their career. How do we help them find new sources of power so that institutions are built towards old institutional power? And Joia, you've spoken so beautifully and has resonated with so many of us, thinking about where is decentralized new sources of power for decision-making ahead. Third, the importance of actually planning and carving out time to plan upstream. That takes resources, talent to detect and plan, to be proactive. And really, I think the most important is that we are truly this incredible collective network. And it's just been an honor of my career to be part of this network and to be of service to the master's students and the faculty and colleagues that are on the line today. Thank you so much.
Thanks so much. Joia, do you want to?
So I think we could, yeah, we could open it up for questions if people want to raise their hands or write a question in the chat. I don't see anything yet in the chat, but and you know, especially since we've had a couple shout outs to Howard and to Marshall, we would love to hear from both of you if possible.
Just a second.
And Bailey is, I think we can unmute people if they are.
Yeah.
I promoted Howard and Marshall to panelists if they would like to join us.
We have one hand up.
Here's Marshall.
Okay, and Abraham Openi from
There you go.
Uganda. Okay, after Marshall, I see your.
Okay, I just wanted to say how wonderful it is to have people like you to make me proud again and again. And the other thing I think is important is figure out what you do best and gives you joy, and do that.
Yeah.
And nobody is good at everything. So figure out what you're good at. It's worthwhile, and do that. But anyway, thank you very much.
Well, thank you, Marshall. I mean, you really lit the fire under me, at least, and Joe, to say we have to make a master's program, and it seemed undoable, really. And we were really the first at Harvard Medical School, and so we're proud of that. And that's become a whole set of master's programs now at the medical school. So great. I don't see Howard, but Abraham Openi from Uganda is on the line. Hi, Abraham.
Hi, I'm fine, Joia. I don't know, my video is not on, but I think you can see me. I failed to unmute the video, but I'm so happy to be in this place. I don't know whether my video could be unmuted.
I'm not sure we can do that.
Oh, it's okay then, no problem. No problem. But I'm just happy to hear from different faculty members and also the alumni and to hear from you, Joia, and the team at Harvard, the Global Health Delivery Program. Listening to the people talking, it kind of resonates so well with the current activity that I'm doing with the TASO, a local NGO based in Uganda, that is doing a lot on HIV/TB program, working with the PEPFAR in-country activity and under USAID program. I think it kind of resonates so well, and I was just getting to know that we have, like, very many people share the same mind, and many people all over the world are interested in this element of global health equity, and I'm also making sure that we reach out to the most vulnerable person in the community. I always like to use the slogan of thinking global but acting locally. I think this resonates so well with the kind of activity that we are intervening with in the community in order to promote and sustain the HIV/TB epidemic control in the different communities. To me, it's just been more of complementing on the knowledge, and I think I am in a good safe space where I get to learn from many colleagues and also maybe share experience with others. Thank you.
Thank you so much. It's wonderful to see you here. And, just to say that TASO is an organization that we have all studied and admire greatly. They were absolutely a trailblazer in the African fight for HIV access. And also, you have been such a champion in your own country for social medicine, which I think is another critical part. So thank you for joining us today. There's a question in the chat from our dean, Johanna Gutluner, about the development of cases, the expense, how they're developed, etc. Professional case writers. So either Joe or Rebecca, if you want to take that.
Sure, I'm pleased to. So, two pieces I'll just say that we adopted early on was the orthodoxy of Harvard Business School case studies. So that means there's a certain lexicon, there's a certain structure and style. There's really like a writing and editing playbook for that. That there's positives and minuses too, but really, actually a lot of the analysis happens in the teaching notes. So we also made a dedication that for each case that we write an active teaching note so that you literally could see board by board how each case would be displayed. And that's a feedback that we get from teaching faculty all across the world, that thank you for writing the teaching notes as well, to make it much more accessible to incorporate one or two cases, for example, in a module, or if you're teaching a class about X to include Y. So we see a significant downloads of the teaching cases. All of the cases have been funded by philanthropic external dollars. So we do not take money directly from anyone we're portraying in the case. nor does the entity that's in a sense involved in the case have final sign off. They have to prove their quotes, but the review process is independent of the entity. So once we're able to bring together some philanthropic dollars, then we have kind of an assortment of folks who've been doing this for quite some time. Then there's clearly sometimes context-specific needs. So we have folks from Senegal when we're writing the Senegalese cases, et cetera. Many of the cases have been suggested by our master's in global health delivery intensive students. And so what we've tried to do, we cannot be comprehensive, but if it hasn't been written about and there's need to explain those teaching objectives, we kind of, are triaging and prioritizing as such. So eager if anyone has suggestions. Right now, we actually are working with Bill Fagey, Mark Rosenberg, a longstanding project we'd had about writing a case about smallpox. Obviously, that got deferred in the midst of the pandemic because Bill's expertise was drawn into the pandemic related activity, but always eager to hear from this community how we could be of help. Joe, please pass the baton.
Thanks so much. I thank you for that question and your explanation. And I see that we do have a question in the chat from one of our alumni, Martha Vega. I should say, and I'll just reiterate that any MMSc-GHD alumnus is also a GHDI alum because people have to do both programs if they're part of the MMSc-GHD. So Martha Vega asks, how do you see the MMSc-GHD or GHDI programs changing in the next 10 years? What new goals do you want to achieve?
I can, for GHDI, I can say a few words that Rebecca and Mary Kay and I have been talking about. I mean, one, I think COVID taught us that we don't absolutely need to be in person, which actually has been very kind of liberating for us because it's been one of the biggest barriers. So GHDI is run for 3 weeks during the summer. Yeah. It's run every day, basically 6-7 hours a day, hence the intensive moniker. The barriers to that, to getting folks to come to Boston, to pay Boston lodging, to travel here, to leave their families, is quite large for many people, especially many people who are actively engaged in a lot of the work that we want to attract. So having done GHDI virtually for the past 2 years, and we're doing it again this year, I think has really shown us that there's some things that we can actually do quite well on Zoom. There is definitely an in-person element that is kind of irreplaceable. So we've been thinking a lot about it. Is there some kind of hybrid option? Can we break it up a little bit so that there's less time in Boston and then some time on Zoom? We've also been thinking of how can we better integrate some of the GHDI work that we do with UGHE. And Agnes has been a big ally in all of this. She's taught in GHDI for many sessions. So I think that's some of the things that we've been tossing around. But Rebecca and Mary Kay, any other thoughts?
And we do have a dream, honestly, of relocating to Rwanda. So, can we do this intermittently? And we think of like in the Old Testament, this is the Shemitah, the rest year. Like, can we garner up enough resources that we could rotate its location and have some hybrid forums, some students are aggregating in one setting together. And I know there's many other forums of the course happening. And it's actually just to survey everyone on the line, how are you teaching global health delivery would be a wonderful secondary capture of this community altogether. As well. Yeah. We've also had a lot of requests for doing GHDI a second time as well. And obviously there's new cases and there's new tools, et cetera. So it's a wonderful question. We'll have to think through resources and timing, but eager to hear interest.
And for the master's program, we've gone through a series of discussions at the Department of Social Medicine where the master's is housed. There is, an appetite certainly for teaching a lot of it online, and we had to do that during the pandemic. we were asked to do a research degree by Harvard Medical School when we started the program, and that was not necessarily our intent. And yet now that we've done it, we really see the value of that, particularly as Mary Kay was talking about, the qualitative, the ethnographic, really the proximity that affords to the poor and to the challenges themselves. And so we're not going to do away. We've made at least the decision for the next little bit of time that we're not going to do. Christina did a beautiful survey, and all the students really appreciated that part of the program, among many. So I think we probably will not change to a one-year program. There might be other one-year offerings from the department, but not our program. And, we prefer to have the students in person. They did okay virtually, but trying, of course, to always think about the cost to students. And, and I just want to say that at UGHD in Rwanda, they have been teaching a master's in global health delivery. The master's is somewhat based on the work that we did at Harvard, with also its own flavor. And so that master's in global health delivery is going on. It is a one-year program. And now all of the medical students have to do that as part of their medical school. So that's going on. And they do use some cases, and many of the cases Rwanda developed themselves. And one of the really fun developments that we were involved in when we first started teaching, cases in Rwanda was that Rwanda wanted to do live cases, and they are so proud of their programs, as well they should be, that they wanted to highlight, a lot of the programs. I mean, Corinne Karema, one of our first graduates from the program in Rwanda, is now I think the director of Malaria No More, some huge international malaria organization, and had led the malaria program in Rwanda. And one of the first live cases that I remember, Joe, was with Corinne, talking about all of the iterations and challenges for malaria. So I think there's a lot of opportunities. We'll keep doing it, that's for sure. Seeing how this virtual world has impacted the masters. I would say in general, I'm happy and proud we were able to do it and get the students through, but I think as our students now who are in person can attest to, it's much nicer to be in person.
Thanks so much. I actually
Howard, I think. Yeah.
Yes.
Oh,
well,
go ahead, Christina.
We'll go to Howard next. I do also want to mention that while we're talking about GHDI and the Master of Medical Sciences and Global Health Delivery, this year marks our department, the Department of Global Health and Social Medicine, is actually launching another master's degree in it's a one-year master in media, medicine, and health, and that's really exciting too. I'll put the URL for that program in the chat just so people are aware of that. So we're celebrating many things: 150th anniversary of our department, the 10th anniversary of the MMSc-GHD program, the continuing progress and work with GHDI, and then a new program in our department, the Master of Science in Media, Medicine, and Health. I want to also just recognize and invite Howard Hyatt to speak. Joia had invited him earlier. So Howard, if you would like to unmute your microphone and make any comments, we welcome you to do so. And I know also sometimes finding that unmute button can be really challenging. Oh, we see you, Howard. We see you now. It's wonderful to see you. But we don't hear you yet. We don't hear you yet. Can you take your mouse and put it over the lower left, the mute? Oh, now I think we hear you.
There's a problem with the microphone here.
We hear you. We hear you.
Sorry. It's been terrific, just a privilege to hear all of you. Just wonderful. Thank you so much.
Well, thank you, Howard, for having so much faith in us. You were certainly the inspiration to create the division, the residency program, and so much of the work, is even building off your vision of the clinical effectiveness program, and adding into that a lot of the tenets of social medicine. And so we're always so grateful for your confidence in us and your leadership.
You're too kind, Joia. Thank you so much. A problem with the microphone here prevents my telling you how wonderful this has all been and what a privilege for me. Thank you so much.
All right. Thank you, Howard.
Thanks, Howard.
Hey, I think we can, Joia, if you have any, or if anyone has any kind of final comments, and then I just do want to remind people about our next events, and just kind of how to be in contact with us. But Joia, do you want to?
Yeah, I'll just say that, you know, what makes this program special are the people on this line: Christina, Bailey, Rebecca, Joe, Mary Kay, and so many of our other faculty, Byron and Mary Jo Good, Hannah Gilbert, Norma Ware. These are people who've really done, Nadeem Kasmani. You know, it's a team effort, and I think we try to model, just like the global health delivery requires a team. It's not about one person. We try to model that. And, you know, one of the best things that, you know, I was, as Marshall and I joke about, I was a Mass General House officer, not a Brigham House officer, but I think the experience we have as residents is always like for the rest of our life. Well, that person was in my residency, and you can call them up even now and say, what do you think about this case? That is what we've created with global health delivery, is this network of people. I was in Sierra Leone just a few weeks ago. I met a person who had graduated from the GHDI program. I met a person who had graduated from the Masters in Global Health Delivery at UGHE, and I met a person who had graduated from our program at Harvard. And they all immediately, I introduced them, and they're all started talking, you know, and so they had never met, but they had this common bond. And then around the world now, we see so many leadership positions now filled by people we have trained in a very different approach that centers equity and justice. And so I just feel like we see our students really changing the world, and it's just very, very moving.
Wonderful. Thanks so much. I'll just take a moment to just see if there are any more questions from the group. We'll just take a moment there. And while I'm giving that moment, I'm going to say I put some links in the chat just about the Global Health Delivery Intensive, again, an amazing three-week program that occurs every year in July. I put the website for the Master of Medical Sciences and Global Health Delivery. As I mentioned, the 150th anniversary of the Department of Global Health. We have an event coming up for that next week. And we will have many more events for the 10th anniversary of the Master of Medical Sciences and Global Health Delivery. And we welcome you to attend more of them. I should say our next event is going to be June 29th, and that will be with an alum, David Angelson, and one of our faculty members, Ann Becker. And they worked together. David did a thesis project, and Ann was his mentor, and they've continued that work beyond his program, continue that collaboration. So we really look forward to that. And again, once again, thank you so much for joining us today. We wish you a wonderful Friday and look forward to being in contact with you.
Thank you so much.
Thank you.